Good morning. My name is Bernadette Biondi. I am a full professor of internal medicine in the Department of Clinical Medicine and Surgery at the University of Naples, Federico II, Italy. Today, I will discuss why thyroid biomarker testing are under the spotlight. I have no conflict of interest to disclose. These are my learning objectives. I will evaluate thyroid biomarker reference range with respect to any individual patients and discuss the need for greater standardization of thyroid biomarker and how this may affect patients' treatment and early diagnosis. I prefer to start with this special American Thyroid Association centenarial article by Professor Carol Spencer. According to Professor Spencer, thyroid dysfunction are among the most common endocrine disorder. The prevalence is about 10% in the US population, and the laboratory tests are essential in the diagnosis and management of most of this condition. This results in an annual cost of approximately $1.6 billion in the United States for the evaluation of TSH, either with or without the free thyroxine. Despite the progressive improvements made in sensitivity and specificity, current thyroid tests remain limited because there are some method differences as well as no specific interference with the test reagents and interference from analyte autoantibodies. And this is the reason why the American Thyroid Association commissioned a review of current clinical and laboratory status. The American Thyroid Association identified an international interdisciplinary working group panel to survey the status of thyroid tests. And during my talk, I will discuss the reason why pathophysiological and pharmacological factors in thyroid assays can affect the evaluation of TSH and thyroid hormone and can confound their interpretation. First of all, I would like to remind you that TSH secretion is the result of a complex feedback interaction between central hypothalamic control, the TRH, and the production of T3 and T4, the peripheral thyroid hormone. This negative feedback loop maintains a level of circulating thyroid hormone and TSH in a physiological inverse relationship, which defines the hypothalamic pituitary thyroid axis set point. There are inter-individual differences in the hypothalamic pituitary thyroid axis set point, and intra-individual variability falls within a narrow range. And I would like to remind you that the individual set point of the hypothalamic pituitary thyroid axis is genetically determined. Therefore, the sensitivity of serum TSH, given the inverse relationship between TSH and free T4, can explain why this hormone is sensitive even to small variation in thyroid hormone. And this can help the diagnosis of thyroid dysfunction. Regarding thyroid hormone, T4 account for about 85–90% of secretion from the thyroid gland, and T3 for about 10–15%. This is because the majority of T3 is produced thanks to the thyroid, to the extratheroidal production, thanks to type 2 deiodinases. Before discussing the use of TSH as sensitive marker, I would like to remind you that the US Preventive Service Task Force recommended against the use of serum TSH for a screening test. The US Preventive Task Force concluded that the current evidence is insufficient to assess the balance of benefit and harms of screening for thyroid dysfunction in non-pregnant asymptomatic adults. However, there are recommendations from other organizations, for example, the American Thyroid Association and the American Association of Clinical Endocrinologists recommended the screening for hypothyroidism in patients older than 6 years, as well as aggressive case finding, but not universal screening, particularly in persons who are at increased risk for hypothyroidism and in women who are planning pregnancy. These are a recommendation from the American and European Thyroid Association, which suggests that TSH is the single best test screening in symptomatic adults, therefore to identify thyroid dysfunction. And the recommendation from the American Thyroid Association suggests that TSH can also be a reliable marker for the adequacy of replacement therapy in hypothyroid patients. They suggest that TSH should be in the range of 0.4 to 4 millionit per liter as therapeutic target. The European Thyroid Association guidelines support that serum TSH is the most sensitive test for the assessment of hyperthyroidism, even for subclinical hyperthyroidism. And therefore, we need the evaluation of serum TSH and consider to measuring TSH alone to screening for thyroid dysfunction. In this slide, you can observe the evolution for the assessment of thyroid function. The first generation, the radioimmunoassay generation for the evaluation of serum TSH, had a sensitivity of about 1. Therefore, this method was very, very important for the diagnosis of hypothyroidism. But we need the TRH test for the evaluation of TSH for the diagnosis of hyperthyroidism. However, subsequently, we had the second and third generation serum TSH immunoradiometric assay, which was able to add a functional sensitivity of 0.1 and 0.01 respectively. Therefore, we now are able to distinguish a low serum TSH and even an undetectable serum TSH. There are some important factors which can affect the evaluation of the TSH reference range. First of all, I would like to remind you that the TSH values do not have a Gaussian distribution because the curve may be skewed by the presence of the euthyroid outliers, the measurement of bioinactive TSH isoform, polymorphism in TSH receptor gene, and the potential inclusion of occult autoimmune thyroid dysfunction. The reference limit of serum TSH may be influenced by various factors. First of all, the time of sampling, seasonal variation, and alteration in daylight hours. It is well known that the serum TSH has had a significant decrease during the morning and a maximum value around midnight, and that cold exposure may lead to a modest TSH evaluation. Therefore, serum TSH may increase during the winter. Interestingly, various TSH laboratory assay may be another reason to explain the difference in the reported TSH normal values from adult population. And this is very important because different methods may detect diverse circulating TSH isoform, which may or not may be biological active, and the reference range may vary even in an individual when different assay evaluation are used. Several factors can assess the evaluation of serum TSH in adults. First of all, sex. Women have higher serum TSH level than men. Ethnicity. TSH can be lower in patients from iodine deficient population and can be higher in white, Hispanic, or Asian race. Therefore, ethnicity and iodine status can affect the evaluation of serum TSH. Tobacco smoking is associated with lower serum levels of TSH, and on the contrary, alcohol intake is associated with increased serum TSH. And it's also very, very important to emphasize that concomitant diseases, both acute and chronic diseases, can affect the circulating level of TSH. During the acute phase of initial disease, serum TSH usually can be lower, and we can have also low circulating T3 levels and increase the reverse T3. And with the recovery of the illness, TSH can be transiently increased before normalizing after several weeks. This condition is usually called non-thyroid illness syndrome, or euthyroid sick syndrome, or low T3 syndrome, and should be considered, especially when evaluating the serum TSH in patients with concomitant diseases. Medications can affect the evaluation of serum TSH. Dopamine, somatostatin, dobutamine, bromocriptine, bexarotene, and even growth hormone, and even high doses of glucocorticoid. Therefore, in this slide, you can see that before diagnosing subclinical hyperthyroidism, we need to exclude other causes of low serum TSH, and in particular, the causes previously referred, therefore, severe non-thyroid illness and drugs. In addition, my opinion is that it's very important to establish the etiology of hyperthyroidism. Therefore, we need the evaluation of TSH receptor antibodies to confirm the diagnosis of Graves' disease, and the evaluation of thyroid scintigraphy and the 24-hour radioactive iodine uptake to identify autonomous thyroid tissue. Moreover, it is very important to assess cardiovascular and bone risk, which can be associated with subclinical hyperthyroidism, identify the best treatment. And regarding the general therapeutic approach to endogenous subclinical hyperthyroidism, treatment is recommended in adult patients who have undetectable serum TSH for the negative cardiovascular outcome, and in patients, older patients, in which serum TSH is between 0.1 and 0.4. There is an increased risk of atrial fibrillation in these patients, which suggests that treatment should be considered. Another important effect on TSH is the effect of age. And in a population-based study, have evaluated this effect. In this slide, you can see the distribution of TSH concentration in a reference population from the National Health and Nutrition Examination Survey and US population. And there is a shift of serum TSH to higher level in older patients, which does not mean an increased incidence of hypothyroidism, but the presence of some important factors which can increase the serum TSH in older patients. Of all, the presence of an acquired central thyroid hormone resistance, because in some older adults, the responsiveness to thyroid hormone appears to decline with age. There is a decreased TSH bioactivity, and also there is an adaptation to aging energetic, which can change. Therefore, there are changes in circadian rhythm, nutritional intake, and chronic inflammation, which can affect the hypothalamic function and which can interfere with the TSH evaluation by altering the hypothalamic pituitary thyroid axis set point. Moreover, there are changes in the activity of the iodinases, and this can also explain the change in the relationship between thyroid hormone and serum TSH. Some other alteration can affect the diagnosis of subclinical hypothyroidism. And after I will discuss the laboratory analytical problem related to abnormal TSH isoforms or heterophilic antibodies, which can affect the serum TSH. And regarding the treatment of subclinical hypothyroidism, it is very important to emphasize that we need to have a persistent TSH increase before treating these patients. And treatment is recommended in all patients with TSH equal or above 10 because of the negative cardiovascular outcome, and considering moderate TSH increase, therefore TSH between 7 to 9.9, it is important to consider the treatment for the negative cardiovascular coronary heart disease mortality, which can impact the patients with the TSH increase in the range of moderate TSH increase. Regarding mild disease, treatment is recommended in younger patients, especially younger adults, especially in presence of cardiovascular risk factor, progressive TSH increase, goiter symptoms. On the other hand, is not recommended in patients above 65 years of age. It is also very, very important to emphasize that the TSH range in older adults can impact the treatment. And therefore, especially in the oldest adults, therefore patients aged above 85 years, we need the wait and see strategy when TSH is moderately increased and treatment is not recommended in patients with mild disease. There is an important effect of TSH related to pregnancy because there are physiological changes in serum TSH during pregnancy. The American Thyroid Association suggests that we need a trimester-specific reference range for serum TSH during pregnancy, which should be defined and should be obtained from patients with in healthy patients with TPO negative in TPO negative pregnant women with an optimal iodine intake and without thyroid illness. And the American Thyroid Association suggests that when pregnancy-specific TSH reference range are not available, an upper reference limit of 4 may be used. However, I would like to emphasize that the method of using a fixed upper limit of 4 TSH may lead to considerable under or over diagnosis compared with the gold standard because of the interpopulation and interassay differences. Therefore, further studies are urgently needed to establish trimester-specific reference range in healthy pregnant women on up-to-date analytical platform. Without such data, the standard of clinical laboratory service in pregnancy can remain compromised and can affect the quality of maternal fetal health care. Interestingly, there is an important effect of body weight on this stage. This is important in obese subjects and can be associated with the alteration in the TSH production from the hypothalamic pituitary thyroid axis and the effect on the thyroid gland. This is the effect of inflammatory cytokine and from leptin in particular, which is produced by the visceral adipose tissue. Leptin can affect the TRH secretion from the paraventricular nucleus. And there is also a decreased TSH receptor responsiveness in the adipose in the adipose tissue in obese patients. Effect of leptin on thyroid autoimmunity can explain why subclinical hypothyroidism can be important, can be an increased risk in patients with obesity. And I would like to suggest this algorithm that I have just published. This flowchart shows that in patients with negative thyroid peroxidase antibody, we need to reassess serum TSH after body weight loss because can be normalized with weight loss. And in presence of a mild TSH increase, we need a periodic follow-up. On the contrary, in patients with moderate severe hypothyroidism, in presence of associated thyroid autoimmunity, therefore positive TPO antibody, we need to consider levothyroxine therapy and to start levothyroxine therapy with a periodic follow-up. And even in mild disease, we need to consider cardiovascular risk factor and even if the TSH is progressively increased before starting levothyroxine therapy. This is there is the possibility that sensitivity and specificity of TSH effect assay can affect the evaluation of serum TSH. This is because some assay may detect biologically inactive circulating TSH isoform. And there are several substances which can interfere in the immunoassay, particularly even endogenous autoantibodies produced by the patients. And the consequences of this interfere can be deleterious because we cannot establish a correct diagnosis and this can lead an inappropriate treatment. Clinical laboratories and manufacturers continue to investigate methods for the detection, elimination, and prevention of these interferences. However, no system is completely devoid of such incidents. I like to show this important algorithm for the evaluation of the interferences with the third function immunoassay. It was published on Endocrine Review, and the authors identified 6 causes of interferences with the TSH and thyroid hormone evaluation: macro TSH, biotin, antistreptavidin antibodies, antiruthenium antibodies, thyroid hormone autoantibodies, and heterophilic antibodies. And they supported that there is the necessity of strong interaction between clinicians and laboratory to avoid these interferences and to improve the diagnosis and treatment of the patients with these alterations. Now, just to summarize the results of the review that I previously showed, which was commissioned by the American Thyroid Association, the author emphasized that serum TSH measurement is the best test for screening primary hypothyroidism in old age. And TSH alone, however, is not sufficient in presence of alteration in the hypothalamic pituitary thyroid axis. That there are some limitations in interpretation of serum TSH, which I previously showed, related to age, reproductive status, biological variation, ethnicity, and iodine intake, drugs. And also, they suggest that there are some important interferences that should be suspected. These interferences should be suspected when the test result is discordant with the clinical presentation of the patient. Regarding the evaluation of FT4 and the evaluation of the utility of T3 measurement, the indication for assessing FT4 are to assess the degree of hyperthyroidism when TSH is suppressed, to confirm the diagnosis of subclinical hypothyroidism when TSH is mildly elevated, to monitor response to treatment even in patients with hyperthyroidism during the first month during antithyroid drugs or radiodine, and to monitor levothyroxine therapy in patients with hypothyroidism. Regarding T3, first of all, I would like to remind you that total T3 measurement is preferred over free T3 measurement, and total T3 measurement may be useful to assess T3 toxicosis in patients with suppressed serum TSH, and also can be useful in the management of patients receiving combination treatment with 8-24 and T3, monitor patients with aggressive suppressive doses of levothyroxine for treatment of advanced thyroid cancer. When we use together TSH and free T4 evaluation, we can detect some important conditions which cannot be diagnosed with TSH alone. For example, central hypothyroidism, or the presence of resistance to thyroid hormone, the presence of factitious hyperthyroidism, and also the presence of drugs or autoantibodies which can affect the evaluation of serum TSH. The results of hormone assay must be reliable given the clinical impact, as previously said, on diagnosis, therapy, and on the monitoring of patients' health and disease. The ideal laboratory result should be comparable over time, location, and independent of the method used. The International Federation of Clinical Chemistry and Laboratory Medicine Committee of Standardization of Thyroid Function Tests documented the status of and comparability of results from both FRT4 and TSH assay from 13 or 15 assay manufacturers. And there are important results from this assessment because they reported that results may differ up to 50% for both FRT4 and TSH. And if method-specific reference intervals are not employed, the classification of a numerical test can give different results and may be different depending on the assay used. This is the ideal approach suggested by the American Thyroid Association to prevent inter- and intra-laboratory variability. They suggest the standardization, and when standardization cannot be achieved, harmonization of test results can be useful. For example, for the evaluation of TSH, because TSH has a variable glycosylation, and therefore the harmonization can be an alternative to the standardization for this test. To address the issue of standardization and harmonization of common thyroid function tests, the International Federation of Clinical Chemistry and Laboratory Medicine created a working group for standardization of thyroid function tests, and the goal was to achieve equivalence of laboratory testing for total and free thyroid hormone, as well as for TSH. What do we need in the future? We need tissue biomarkers. We know very well that there is an important effect of thyroid hormone on tissue, especially on the cardiovascular system, on the bone, and that, for example, that thyroid hormone can alter the lipid metabolism. Therefore, we need a peripheral marker to assess the sensitivity of each patient to the effect of thyroid hormone. This would explain why some patients can be still symptomatic even when completely euthyroid during the replacement therapy. And in the future, it may be useful to adopt based the reference range based from clinical outcome. This is why the authors performed this systematic review to assess individual participant data meta-analysis to define the optimal health range of thyroid function by assessing the risk of cardiovascular disease and mortality. And finally, the future is probably the artificial intelligence for the thyroid disease management. The application of this method to laboratory medicine, to test also for the diagnosis, for the monitoring of thyroid disease, can allow clinicians to optimize correct tests, to have a good interpretation of this test, to have an optimization of the assay design and for the decision making process for the therapeutic approach. These are my take-home messages. The evaluation of TSH levels is the initial test to assess thyroid dysfunction. Measurement of thyroid hormone should be added when TSH values fall outside of reference range to allow clinicians to distinguish between overt and subclinical thyroid dysfunction. The evaluation of thyroid function is affected by nutritional, environmental, geographic, genetic, pathological, endogenous, exogenous factors, and laboratory assay. And clinicians should be aware of the method used, the limitation of each assay to reduce the risk of an incorrect diagnosis and an unnecessary treatment. The standardization and harmonization of tests will facilitate the establishment of a universal reference range. And I would like to thank you for the attention.